I brought some examples of some things that we've done with our cohort studies that are run out of one of the centers that I direct. To kind of respond to kind of around the theme of how do we respond faster using existing cohort studies and existing resources. So what I'm going to talk about today, it's going to be pulling data from a lot of the different centers that we've got. I will try not to use too many acronyms, but the studies that I'm going to talk about, they live in the Michigan Center for Respiratory Virus Research and Response in terms of enrolling and collecting samples and testing samples for folks. We've also got this partner center called MyCom, which is focused on, it's funded by CDC to be focused on preparedness and outbreak and analytics and modeling. And that is very closely linked with MDHHS, that center is. And then we've got wastewater information coming from Krista Wigington and Marissa Eisenberg's laboratory. And then we've got sequencing information that's integrated with all of these pieces coming from, there's a Center of Excellence for pathogen genomics that's located at U of M also. And so Adam Loring runs that center as well. So what I'm going to be showing you today, we've gotten to the point where we're integrated, and it sometimes don't even remember which piece of data comes from which centers, because we are kind of constantly sending things back and forth. When an outbreak happens, or when an incident situation happens, we often are able to just bring all of these connections together right away and start pulling data across the different silos. We are also working on what are ways we can push our data to be public faster. And this is something that became very important as CDC became less able to push information publicly. And it was a big conversation around the time that strain selection was happening, and the US wasn't able to provide basic epidemiology information to the international community to inform what was going to be part of the next flu and the next COVID vaccine. And so we've started to try to push all of our testing results onto the web as quickly as possible, including Midge is now pushing their sequencing results. And this is all stuff that's mostly relevant to Southeast Michigan. You can see Southeast Michigan specific clade data, strain data, and virus circulation data when it's available. So the first study that I'm going to kind of ground everything in talking about is called the HIVE study. It's a household, now it's called the Household Influenza Vaccine Evaluation Study, because we like to evaluate lots of things about the vaccine, not just whether or not it's effective. Some years it's not. And this is a prospective cohort study of households with children. And it's these households are enrolled around Ann Arbor. We've traditionally enrolled families that can come to the clinic on site and get samples collected, although we rarely use the clinic anymore. So we can enroll whenever, but we do a push for recruitment in the summer. We collect a blood before respiratory season starts, before vaccination season starts. And then we collect another one in between vaccination season and when the viruses are circulating. And then we collect another blood at the end. For HIVE, it's important to note that we are also, so we ask every week if anybody in the household is sick. And if somebody is, then we collect a swab and we test it for all sorts of PCR tests, depending on how much funding we have at the moment. And so we have one illness swab that's collected on the day of illness. So HIVE, it's been around since 2010. We have some families that have been with us for almost 10 years as part of the study. It is designed to capture households with children. So we tend to get adults on the middle to younger adult age, and we get kids. We don't get a lot of older adults in our cohort, and we don't get a lot of young adults in our cohort. So it's really useful for talking about the epidemiology of symptomatic illnesses. It's going to be less useful for talking, by design, it's less useful talking about asymptomatic illnesses, but I'm going to show you a few things that we've started to do with it. It's nice because we have this pretty intense consenting process that's linked to routine participation. We have the participants linked to all of their medical records that we can access. We can pull those, and we also have a linkage with the MDHHS MICR, with the vaccine registry. So we also have real-time linkage to vaccine records as they're getting vaccinated. The consistency in design has been nice to be able to look at year-to-year variation. And because they tend to be closer in, this study tends to get what I call our hyper participators. And so we are able to collect a lot of blood specimens. They'll come in repeated times for their blood. We collect PBMCs, which is a much larger draw. So we've been able to get a really wide variety of specimen types. We've also this year been piloting collecting mucosal samples. So it's a sponge that gets held in the nose for 15 seconds. So try to do that with a baby, right? Try to keep them still. But you hold the sponge in the nose for 15 seconds and we can start to get at things like mucosal antibodies. And then we're going to start looking at mucosal cytokines. So this is, but what Hive has been very useful for, and we've started to use it in the last year or two, is thinking about how do we use that first case report? How do we leverage that information? Because we know that that's a moment in time that everybody else in the household has now been exposed to virus. So one of the big issues with infectious disease studies, transmission studies, but just in general, is that the moment of transmission happens at a specific moment in time, right? There's a sick person that coughs virus at a susceptible person. But we tend to analyze the data at best on like a seasonal scale. So we tend to analyze it for like all of December or for all of, 2024 to 2025. And so we're missing important data about whatever is happening at that bit of time. We're sort of assuming that everything else is equal on every other day. So we're trying to get away with that get away from that now by thinking about susceptibles as people that are living in a house with a documented exposure that we can document, okay, virus was in this house on this day. So currently we've got, as of last count, as of last July, we had over 1,000 individuals in this cohort from 315 households. We get about 2,000 samples from about 2,500 illnesses. And we got over 100 flu cases that we found last year. We also are testing now, as samples come in, we're testing regularly for SARS-CoV-2 and RSV, although that might start to go away as our funding has been changing. But here are the types of samples that we've got from the last year. So traditionally, this is what we tend to see from your average infectious disease surveillance cohort study, right? You see the curves with what happens every year. Because we started, so this is actually starting in 2015, these graphs. And if you look all the way to the left, you can see, some things like, for instance, HPIVs tend to have very different patterns from year to year. But then something like HMPV or RSV tends to be more regular from year to year. And then you can also see here during the 2020-2021 or 2020-2021 period, you see some flatlining. So this is when all of the other respiratory viruses went away, when the COVID precautions went into case. And we surveyed our cohort a couple of times, and these folks are hyper participators, and they're also like hyper isolators. They were not going anywhere. And so the survey data matched what we were seeing in the results, that like really exposure to viruses was going down. Interestingly, rhinovirus came back really fast, even under very high levels of mitigation, right? Rhinovirus only went away during the most severe isolation procedures. So rhinovirus comes back first, and then the other coronaviruses come back second, up on the top left corner. So kind of describes why coronavirus was so, as a family, they're so wily and difficult to control. But if rhinovirus ever becomes dangerous, then we're like, we have big problems. So we've been working a lot this year, like I mentioned, how do we move out of that paradigm of just like calculating these curves one and another and being able to provide more granularity so we can start to talk about things like transmission in a better way. And so before I start, I wanted to give a quick reminder of how antibodies work. When you've got, especially when you've got these viruses that are coming year after year. So you've got this moment of transmission. This gentleman here is coughing out this virus at this point in time. You've got people in the household that are going to have some sort of pre-existing level of antibody that we measured at time Band-Aid 1. And they could have high levels of antibody, they could have low levels of antibody, depending on what they've seen in their life before then. And then we were just talking about like, it goes back to birth. With flu, we've seen patterns around what year you were born in and what your cumulative profile is by the time you're actually exposed. So you've accumulated all of this profile and this combination of risk factors and susceptibility factors that all manifest at this one moment in time when the person in the household coughs on you. So your antibodies, if you have a primary exposure, you're going to have very low antibodies. They will go up and they'll come back down to kind of a stable place. A secondary, it'll start higher, it'll go up, and then it'll also kind of come back down to a stable place. But something that, and then we collect this blood sample at the end of the season. Now, pre-universal influenza vaccine, epidemiologists used to use the difference in titer between these two Band-Aids to be able to see if somebody got an infection, but it wasn't detected. So we basically see, and this happened a lot during COVID too. People would get a COVID antibody test. They don't remember having COVID. They don't remember being sick, but their antibodies are higher. You can do that with an emergent virus because you start out low and you go up to high. When you've got a situation that we're moving into now, though, when there's more endemicity happening, there's more circulation regularly, you've got two different effects that are playing into your ability to be able to use blood antibody data. One is that everybody's starting higher than they were before. Two, after you've peaked, after your vaccine or your infection, you don't come actually down to a stable point. You come down to a slow decline that's going to happen over time. So if you get exposed again, whatever happens right here, whenever that happens, the moment in time in which you're asking the vaccine or the prior exposure to protect you, your level of protection is going to change the further away that you get from your vaccine or your infection. So you remember this during COVID, they were talking about, well, you need a booster because it has waning immunity. This is what waning immunity looks like. So we had a graduate student, she actually just started a position at Vanderbilt, she just graduated, who looked to see if she could look in the past 10 years of data prior to the RSV vaccine that's currently available, looked before then kind of the vaccine naive era, and see if what information she could get out of kind of comparing these two Band-Aids to each other. So what she did is she took all of the households from 2014 to 2021 in Hive and took any household where anybody was sick at any time with RSV. So we have the day that that person has a symptomatic illness that they swabbed and they ended up being tested for RSV. And the cool thing about using household reporters is when they call in an illness, you can say, okay, who else in your house is sick? So you also get negative confirmation that everybody else was not symptomatic yet. And so when we do the follow-up, we were able to get positive or negative confirmation on the other people in the household. So she started by identifying, so she identified all these households. She measured the pre-fusion antibody or the antibody against the pre-fusion target for RSV over time. So she measured all of the antibody levels pre-post, the pre-post time points. And then she did some antibody dynamic curves and ended up finding the following. First, So pre-infection, pre-exposure. So the first blood sample we got prior to the season starting, cases, and then you've got household contacts here. And they're next to each other. You've got some people in the very low concentration of antibodies down here, and these are likely because you've got infants or little kids down there. Then you look at the post-infection exposure. In the blue here on the left, this is the first person we identified that was sick. Luckily, everybody's got antibodies now. We don't have somebody that's still like antibody naive on the bottom. And then those are higher. So in our contacts are going to be a mix of people that had secondary infection and a mix of people that continued on uninfected. So this is going to be more variable here. So it looks about the same. And then as you extend out into the future, you see that the cases now, by next year, by the following year's samples, you see spread here. So some of them are starting to lose their antibody level that they had right after their infection. Okay, so what can we do with this information that's useful? First, notice we aren't measuring the blood at any relevant time point. We're bracketing relevant time points, but we're not measuring it at any relevant time point. But because we have the day of illness of the case, we're able to start to think about what the trajectories of protection are, what those antibodies, so I drew for you a cartoon of what those antibody curves are, but we were able to reconstruct what we think the antibody curves are after an infection and or a exposure happens in a household. So that is happening at that dotted line here. And we're seeing the cases up on top. They are having higher antibodies quickly after exposure, the model says, and it's going to start to kind of come down in time. And then here are the predicted values in yellow on the bottom with where the household contacts were. We used basically the rise that we were detecting in the cases compared to prior years to set a threshold for what we thought infection would do in this population in terms of antibody titer. And by doing that, she was able to identify how many people in each household we think were having asymptomatic infections. They were basically having asymptomatic antibody boosts. And so we were missing, they weren't symptomatic, at least they told us they weren't symptomatic, which is the best that we could go on. But we were seeing a bump in their antibody titer that reflected what the case antibody titer, what the infected person in the household looked like. And by doing that, we were able to start to estimate how much the titer changed between the different specimen time points. And then kind of come down here. So this is her kind of figuring out what her thresholds are here. But that can be used, put then into what's called a correlative protection model. So a correlative protection model is when we say, you can say, okay, does having a prior infection protect you against future infection, or does having a vaccine protect you against infection? But what you're really asking is, does having a certain quantity of antibody in your body protect you against infection, no matter how that antibody got there? So one of the big questions of RSV, because you've got all of this background and movement in the antibodies over time, it's been an open question how much antibody you need, pre-fusion targeted antibody you need in your body to prevent the next RSV infection, and how long you hang on to that body. So she was antibody. And so she was able to calculate an initial like threshold, like basically a 25 decrease in hazard of infection for every 1 unit of the log4 transformed antibody. So she's basically able to estimate how much you need to boost that up. So now we can take that and apply it to these various vaccination programs to start to model out, okay, if you've got people who already have high antibodies and you push them a little bit up above their background, how much protection do we think we can gain from a vaccine? It's a very roundabout way to predicting whether or not a vaccine is going to work, but it's what we do in the US when we update vaccines. We use these immune bridging measures. But I'm going to show you the real data in a minute. Okay, so the other thing that we realized we could do once we were doing this sort of moment in time exposure fixing was going back. So this is going back to a question I was obsessed with when I was at Wayne State. Don probably remembers this, but it is that if you actually test people for the range of viruses, they're going to be infected with the range of viruses more so than you would expect. I mean, I had kids that we tested weekly that were in childcare that would get had 3 viruses at once. I had other kids that they'd be infected with one virus and then they would get co-infected with a second virus. And then when they would get rid of both of those viruses and they would start a third virus, like all in the same illness. So viruses, we tend to use that one swab testing, but they're actually more of a dynamic population that we typically give them credit for, which leads to a lot of misclassification issues when people start to ask the question, what happens when there are 2 viruses circulating at the same time? So I don't remember if you remember the conversations around the triple-demic. So coming out of COVID, it's weird because everybody's got a frame of reference now for like the stuff that we've been looking at for a while. But coming out of the pandemic, there was a situation where, okay, COVID's still around, flu's starting to come back, RSV's starting to come back. And yes, you know, pediatric hospitals were getting hit really hard. There was a cumulative impact of that. But there were people like expounding on whether or not having a big wave of one virus is going to stop a wave of another virus, whether they would outcompete or interfere with each other. Now, I have always believed that that can't possibly be true because I think that one wave changes the behavior of people. I also think that like, just, you know, their animal models was showing some evidence of an interference effect of 2 viruses, but it was never enough that I really felt like it could change the whole wave of a whole community transmission pattern. So I've always been arguing on the side of this. I'm sure this doesn't happen. It has to be confounding. Like it has to be an ecologic issue. So Jessica, who is starting this week, actually a position at Boston University. She's not a PhD candidate anymore. She's Dr. Ibiabelli. So she took me on and basically was like, okay, so we're going to take all the households where transmission happened after a documented index X case. We're going to see what other viruses everybody had in the household and see if we can actually see one virus blocking another. Sample size, this is hard to do. And so she had to basically take advantage of all old 10 years of data in order to get enough data to try to look at these. And because she was using the old data, so remember, this is only symptomatic infection we're able to talk about. Asymptomatic infection is probably important in this context, but she wasn't able to look at it. So she kind of sketched out the 4 different options. You can have one person with one virus go into a household where nobody is infected with anything. You can have one person with 2 viruses go into a household with completely uninfected susceptibles. You can have one person with one virus go into a household where everybody in the household has a different virus and they may or may not get your virus. This is category 3 is what people are talking about when they're talking about blocking. If everybody already has COVID, maybe you can't give them flu. And then category 4, which are called daycare, you've got one person with 2 viruses trying to infect another person with different viruses. And so in which of these boxes does transmission happen more often or less often? And this first pass, she did not do with a model. This is just typical analyses, finding all of these combinations and seeing what the data actually did. So she looked at this at the household level. I'm actually going to skip past this. Basically found that the more viruses were in a household, aggregate, we saw transmission be lower in the households that had more viruses. But if you look at those different categories, So I've got the notes down here because I always get this wrong. But basically what this is telling you is that for the index case, for people that were co-infected with people who were infected with two viruses at the same time, their risk of transmitting went down. But for people that were infected with another virus, their risk went up. So the other person in the household that was infected with somebody else was actually more likely to get infected. But the person that walked into the house that was infected with two things at the same time, theirs went down. It was unexpected, both from her side of the bet and my side of the bet. It's like we both lost. So the next step, like I mentioned though, so this paper just came out earlier this year in Nature Communications. We followed that up with, so beginning with a follow-on study that allowed us to now start to add asymptomatic samples. So how do you do asymptomatic samples in a cohort study without spending like $1 billion? We started to do what we've been calling this a nested case ascertain design. So the usual in outbreak, if you've ever done an outbreak response, one of the really common things to do is you do a case ascertain study. So you basically find your initial outbreak cases and you say, okay, everybody you came into contact with, we're going to enroll them in the study and see how long it takes for them to get sick. The problem is with respiratory viruses, by the time you enroll all those people in the study, they're already sick. So I have run now several case ascertain studies that have totally failed because you can't do that ascertainment fast enough to actually get an uninfected person and watch them become infected. So right when COVID started, we said, okay, anytime anybody's sick in the household, we don't know what's going on, everybody starts swabbing. We're gonna we mailed them these boxes full of swabs. We had these like little takeout containers with the little handle, and everybody would swab. And because the biohazard stuff hadn't been worked out yet, we had a staff member standing on the driveway out behind SPH2 in Ann Arbor with a bucket. And we would have families drive up and they would wear PPE and we would wear PPE and they would drop it in the bucket. So this is how we started doing this serial sampling. So we started with everybody swabs at day 0, 5, and 10 when anyone in the house is sick. So this helps us get to the front end of that serial interval before one person gives it to another. And so during that time, remember I told you that beginning of that time period, there wasn't any flu, there wasn't any RSV, but there was COVID and there were common coronaviruses. So those are the ones that we focused on to be able to do this analysis, and then rhinovirus, which was sort of always around. So what you can see here is we kind of have a mix over time of exposed contacts, then contacts that were infected with other things, and then index cases that are infected with other things. So these sort of same groupings that we thought of before. Make this bigger again. And when she ran the same sort of way of looking at it, here's what she found. So the only the power is a challenge here, but found that exposure to a co-infected index case reduced the amount of transmission that was happening in this scenario. Now, this is when you are also taking into account asymptomatic infections. But when you are a contact infected with another virus, and these ones different from the previous example, these are the contacts that are infected with another virus, and most of these are asymptomatic infections. And here we're seeing that mild infection. It's not significant, but the estimate is lower. Then we're seeing blocking happening. We're seeing it happen on the contact side, but we're only seeing it when we incorporate asymptomatic infections into the pattern. So this is stuff we're still working on. It's continuing along, but she has put this into a hazard-based household transmission model. to try and get at what impact would this have on a population scale if we have these hazard reductions on these different transmission things. So this is sort of my theory of like, okay, it might happen, but it can't possibly happen enough to change an epidemic. And the model's still in development, but the preliminary results are that, and just taking that first result, the co-infected index case, basically saying if you have a co-infected index case in a household that starts out with a secondary attack rate of 72%. So we tend to see really high secondary attack rates in households, as you've lived in households, you can imagine. And so if we start with that as the percent of households that have co-infected index cases in them in like a population, you start to see these sort of decreases in the population-wide secondary attack rate that will develop. And so seeing the transmission pattern go up. So it is going down by, it's going down by 10%. So it's not nothing. She hasn't taken the step to see what this would do to like wave dynamics. But we are, so I conceded this one. I do think it has the potential to matter more than we anticipated. So following on that example with the asymptomatic swabs, as we were piloting that in 2020, like one person gets sick and everybody collects, we got a contract from CDC to basically do weekly swabbing of as many people as possible. And so that finally, the contract took 18 months, which is not pandemic speed. But in 2022, we started a project enrolling more families, and we expanded to the whole state. And we were having everybody collect a swab every week, whether or not they were sick. And then if they became symptomatic, they would collect more swabs at that point. We were also doing home blood draws using tasso kits. I don't know if anybody's used those, but they stick to the side of your arm, and you push this button and it's a microcapillary draw, and it fills this little tube, and then you peel it off your arm like a leech and you literally mail it back to us. So we've been collecting blood specimens all over the state of Michigan using these tasso kits. Because we use them for antibodies, we don't use them for RNA viruses or anything like that. The antibodies are stable enough that we've had pretty good results from being able to do this. It's a little trickier when you get into other blood detection issues. So the way that we design this, Hive has kind of strengths in intensity and completeness, but limitations in terms of generalizability and the area of Michigan. Cove allowed us to expand to the whole state, but we had to bring down the intensity of participation by a whole lot. We also, this was another thing I thought would never work, but then it did. The social media team at the hospitals have very active social media teams, and they can find like a profile and a zip code in one place. I don't know. So they did the recruiting. So, and it went nuts. It was so much enrollment that we had when the social media team started doing the targeted recruitment. And then we also, invited our Hive families, and like over a third of the Hive families was like, we'll do more. Hyper participators. So here's our coverage on the Cove study compared to the Hive study. And it's interesting because we've got like density from Ann Arbor to Brighton, Howell area. And some of that was intentional. I'll show you why. And then, but then we've got this smattering of people all over the state. And then because this county includes Isle Royal, I get to count like the one moose over there as being in my catchment area. But yeah, so we get people just kind of all over. So we don't have the geographic restriction. Unfortunately, we don't have enough coverage to be able to do like sub area analysis like I'd really want to. So this resulted in a ton of samples. And we designed it in partnership with another cohort that was starting in Tennessee and another cohort that was starting on the West Coast such that we did a harmonization activity up front so that anytime any big question came up, we could compile our data without doing additional cleaning steps, so that we could get to big sample sizes if we needed to immediately. So it was all baked into the processes. And we did that. So the first big one we did was looking at, this is say 2022, but when the bivalent booster came out in children, there was already a big debate about whether the vaccine was working in children and whether it was effective in children and whether children were even getting infected at all. And we were able to combine, so this is a Feldstein et al. JAMA 2024. Save this reference if anybody ever tries to tell you that nobody ever showed that the bivalent booster worked in children, because it reduced, because we were collecting weekly samples, we could analyze this effectiveness against all infection. So we could look at, was it preventing symptomatic infection, but we could also see if it was preventing asymptomatic infection. And we were seeing about a 54% reduction against all infection and a 49% reduction against symptomatic infection in this 5 to 12 age group that had been and they're now like not recommended for the vaccine anymore, that had been so controversial. So we followed it up by looking at the very little kids. Didn't see a lot of infection, a lot of risk, but then we also followed it up with the bivalent booster in adults as well. Didn't see as big of an effect, but we did see an effect in adults as well. I've got a whole different talk on vaccine effectiveness and why the numbers don't mean what you think you mean, but I'm not going to give that today. But just park that topic for later. So here's what Cove looked like if you look at the part of Cove that was added into the cohorts. So we've kept it open. We have gotten rid of most of the asymptomatic sampling. We had to do a lot of cost-cutting measures with various federal cuts. But we still have almost 600 current participants. And we're still bringing in over 1,200 illness specimens a year. It's interesting, our just the whole characteristics of the cohort are different. Like our education level went way down, our racial diversity also went way down. Our I think our socioeconomic profile has changed. It's just a very different group when you look at the two. So as I watched the social media team play with the algorithms to kind of get different groups, try to get different areas of the state involved in different groups, we had an idea. We were like, well, how do we prioritize? Like, what if we have just so many people that are interested in the study, we can't take them all? And we decided to start by prioritizing areas where wastewater was being collected. Because at the time, there's still a lot of questions about what do detections of wastewater mean. And so here we would have a sample from people in the community as well, and we'd all have all the hospital and medical data that we usually have, and then have wastewater data and be able to overlay that. And so that's how we ended up with the shape of some of the catchment areas that we had, because we were trying to overlay, enrich for sampling where we've got wastewater data. We've got a group that's now working on trying to see where those surveillance systems correspond. And this kind of zoomed in version, but here's all of the systems lined up and see where all the viruses correspond with the actual surveillance data and not with the surveillance data. It's interesting because they definitely tell you, they kind of in the broad sense move with each other, but they definitely tell you different pieces of information. But what we learned from doing that adaptation became really helpful when the RSV vaccine rolled out in adults 60 and older. So remember I told you our cohorts tend to have households with children in them. We don't have a whole lot of older adults. But as the vaccine got approved, CDC looked across all their platforms and said, we have no monitoring system for older adults. We have no actual observational stuff ready to go to see if it prevents moderate to mild illness. So I went to the social media team and I was like, I need you to find me some grandparents. And so they shifted the algorithm of how they were recruiting. And then this bottom line, you can see that in that year, we went from no older adults at all in this blue line to like, look at it pick up. So all of our new enrollments during that time were all of these 60 and olders that saw the ad and replied to it. And so we were able to, like back when I started doing vaccine work, you used to release a vaccine effectiveness estimate like 2 years after the season was over. You like clean the data, you take it to a conference or whatever. We had this calculation done by May. So here is during the first season the vaccine was available, and this was really tricky because the vaccine was being released during RSV season, so the risk period was very complicated. But and not significant, but if you look at the point estimates, the cases are almost all in the unvaccinated folks, and very few cases in the vaccinated folks. And if you look at then going back to the beginning of the presentation, thinking about using antibodies as a proxy for protection, here we've got these bar graphs down here with buckets of people in different antibody groups. So these are people in the lowest antibody group. To the right are people with the highest antibody group. This is irrespective of vaccination. I don't care how they got to what group they're in. But prior to the season, here's where they started with their antibodies. And the red line is the percent of the that got infected in that group. And as you can see, what you want to see you want to see it go down. You want to see as a person has more antibodies, do they have a line going down? And so led us to be able to look at a first estimate in now what is the decrease in odds of infection in a population where you're looking at vaccine elicited antibodies, not just infection elicited antibodies. So we are now finishing up testing the specimens to look to see how these people did in year 2. So we turned on asymptomatic sampling again during RSV season for the 60 and olders so that we can see now whether there's a signal that the vaccine protection is dropping off in these older adults, or does it seem to be staying just as high? So we'll be able to look at the blood, and then we'll be able to look at the change in infection. And to kind of go back to what we talked about in the beginning, so we've been able to use this data, and then we've been fitting different types of curves to try to see what that drop-off, that antibody drop-off that happens during the season, what does that look like in somebody that got their antibodies only through natural infection? Since this was the first vaccine available for RSV, we know that all of these people got their antibodies through natural infection. And these people have gotten their antibodies through a combination of natural infection and vaccination. And you can see that, with the exception of the very long-term points, which are totally outliers, you have a level change, but mostly the same drop-off trajectory happening in the naturally infected people versus the vaccinated people. So that's good. Like, there are some COVID studies that are shown that the vaccine drops off a lot faster than natural infection. And so this is a good sign for the vaccine. Although I had a lot of meetings with CDC about this point right here. Like, why is that so low? I don't know. But we're going to check them a year later to see if they're still how they've done. So that is what I have for you. Obviously thanks to all of the labs that participate in these projects, and the NIH funders and the CDC funders, and our awesome team that works really hard. And that's what I have.